my role this evening, as I see it, is to essentially raise people's awareness about the role of the board-certified behavior analyst, or BCBA, in general in the treatment of autism, and this evening in particular when addressing mental health problems. Now, I never want to assume that the general population knows or understands what a board-certified behavior analyst is, so let me quickly define that professional. A BCBA is essentially a behavioral scientist clinician who has a graduate degree in a related area, has completed required coursework and approved coursework in behavior analysis, has completed clinical training, and written and passed a rigorous certification exam to become a board-certified behavior analyst. And board-certified behavior analysts provide services in a wide variety of ways. I'll be speaking primarily this evening from the service model I work in, which is providing comprehensive behavioral treatment over a long period of time, longitudinal treatment. So in many cases, I'm meeting preschool children and doing their assessments, designing their intervention, and supervising the implementation of their behavioral intervention from preschool all the way through school entry and into high school and sometimes beyond. So the interesting thing about that service model is you get to see the longitudinal growth and development. And what are we working on? We're treating the triad of impairments that define autism. So we treat and teach skills to address language and communication, social, and play and repetitive behaviors, which is, again, the triad of impairments defining autism. Services from behavior analysts broadly can fall into these domains, although this is not exhaustive. So we teach language and communication, from basic communication to have their immediate needs met, all the way up through conversational language and whatever is functionally required for each individual. We teach social and play skills, and social skills might start with just simple proximity to peers and turn-taking and sharing, and then all the way up through high school where we're learning the social skills to have friends and to navigate social media, to have a boyfriend or girlfriend, and eventually to get a job and perhaps to succeed in university. We address fine and gross motor development, everything from holding a pencil correctly and printing your name to riding a bicycle and tying your shoes. We address the full range of academics, from preschool, kindergarten readiness, learning your alphabet and colors and shapes, all the way through numeracy and literacy, and in some cases teaching composition and algebra and calculus and preparing for university. We also teach skills to address deficits in adaptive daily living skills, organizational skills, executive function skills, making a sandwich, brushing your teeth, taking the bus, and finally addressing some big things like toilet training, sleep training, and feeding issues, which affect many of the families that we work with and the children. We also do functional behavior assessments, where we assess the function of problem behavior and design positive behavior supports to teach replacement skills, teach more effective communicative behavior to replace problem behavior, and increase quality of life along the way. Now, in my practice, as I'm providing these types of services over the long term, it's not uncommon to have mental health concerns emerge in a certain number of children and youth that we work with. The most common that I see is ADHD, which Dr. Bailey alluded to, but I also see a lot of anxiety and OCD in my practice. And since I'm there and many of my colleagues are in this longitudinal service model, we're often able, with our history, to see the emergence of some concerning things that might lead to the diagnosis, and we might be the primary point of referral. Board-certified behavior analysts are all serving children with autism should also be autism specialists. And autism specialists, we're sensitive to the potential for comorbid disorders and diagnoses. We're vigilant in looking out for unexplained and sudden behavioral change, and then prepared to make appropriate referrals. And more often than not, that does lead to the diagnosis that we are suspecting, although not all the time. I was working with a young man a number of years ago, and he had a kind of a perennial problem with fixating on peers. And as he approached puberty and moved into high school, it exploded in a way we'd never seen before. And it was disruptive in a way we hadn't seen before, and it didn't respond to strategies that had worked previously. So this led to a referral to a psychiatrist, and he went and had an assessment. And I got a call from the psychiatrist who said, sorry, there's no diagnosis here. There's no pill for this. It's back to you guys and back to behavior. But at the very least, in that case, we ruled out a psychiatric condition or mental health problem. As I said, though, more often than not, the diagnosis that we think is likely to occur is provided to the child. And at that point, then it becomes an issue of working collaboratively with other professionals as a team for optimal management of the disorder, the condition. And this requires sharing information and requires a coordinated approach. as we're identifying the problem, during the course of diagnosis, and then certainly after the diagnosis as we move into long-term treatment. So I often have brief phone calls with the psychiatrists or general practitioners early on in the process and have discussions and share information with them, or through email. Sometimes we attend the meetings. But then in the long term, it's typically done through the parent, where we're often collecting data on the occurrence of problem behaviors, on the presence of side effects, and that is often very useful data for the parents to take to the meetings with their mental health team, whether that's every 3 months or every 6 months, or according to the child's needs. Additionally, we're often involved in the schools, and so we're able to be a link between what's happening at home and the school, and again, just providing a greater wealth of information to the family when they liaise with their mental health professional. A few quick case studies to kind of illustrate how this works. John was 13 years old with autism, quite verbal. He was diagnosed with an anxiety disorder. The topography was a fear of germs, so he would be covering his mouth, which interfered with his ability to answer teachers' questions in school, interfered with his ability to be socially appropriate with peers. And he was also spitting, just outright spitting, which was very offensive to peers and socially stigmatizing. And the effective treatment for him was seeing his mental health professional, a psychiatrist. He had a very successful course of medication. He also saw a psychologist who did cognitive behavior therapy on a weekly basis to address these topographies. And then my role as the behavior analyst is to help manage the environment. And so in this case at school, the environmental arrangements took the form of a differential reinforcement procedure where we reinforced him for periods of time where he refrained from spitting or covering his mouth. And then he earned tokens which were valuable to him. There was also a response cost component to that, so that if he did spit within this interval, then he owed the principal a minute after school of detention, which he wasn't very happy to do, but he only wound up having to spend 5 or 6 minutes a day during the first week. And then the contingencies in combination with the CBT and the medication took hold and were quite effective, and he no longer had any after-school detentions, and he could refrain from spitting and covering his mouth. So what was effective was the treatment team altogether, not just one part of it, not just the behavioral strategies, working against the biology or a pill, thinking that that's going to solve everything when the environment hasn't changed. Additionally, we have the benefit of having monthly team meetings where we get everyone together and we can continue to stay on top of these things and track them and take data, share information with the psychiatrist, and psychiatrists can guide us on what to be looking for around side effects and things like that. Final case study, Robbie, 15 years old with autism, also had anxiety, but the topography of his problem behavior related to his anxiety was high rates of stereotypy. So he would script from movies. He would say whole sections of movies out of context, which was socially inappropriate. And what worked well for him was seeing a mental health practitioner. He had regular visits with a psychiatrist, a successful course of medication, and then a differential reinforcement system at home where we were able to show that he could refrain from engaging in stereotypy, even during periods of high stress, for up to 2 hours at a time when he was reinforced every 7 or 8 minutes. And so that shows the success that it's not, he doesn't have to be doing it all the time. We are able to effectively control it. Granted, it's only for 2 hours at a time in a tightly controlled setting. So over time, to make it meaningful for him, continuing to work with the psychiatrist, we exposed him to stressors in the community, to dogs, to unexpected people in stores, taught him additional strategies around deep breathing, and he would clench his hands as a kind of a progressive muscle relaxation strategy. And the combination has resulted in very significant quality of life improvements for him. And he's learned the skills, continuing to address the biological component that's allowed him to successfully live with his anxiety. And that's it for me. Thank you.